Well, hello everyone, and thank you for being with me today as we review perhaps one of the most interesting and controversial topics we have today. That is, how best can we deliver myopia controlling optics into our children's eyes? This story actually begins with a clear understanding of all of the different optical interventions we have available to us today. Now, the reason this is so important is that unlike other disciplines that we practice, we really can't go by our evidence-based numbers because we are sitting across from a child and the parents, and we really have no idea that child's myopic journey. That is, how myopic they're inevitably going to become. We also don't know their individual response to our various myopia controlling therapies. Therefore, much of what we do today in clinical practice is a wait and see situation. We place the child into one of our optical interventions and we follow their axial lengths to see how that individual is going to respond to that specific therapy. Now, what this means for you and I is that we have to have insights into all of these different myopia control strategies because, frankly, we have no idea how a child is going to respond to any one of these therapies. And we have to be able to make changes quickly to get that child introduced into a modality that is hopefully going to be effective for them. Now, I can't think of any better place to start than with what has been the gold standard for myopia controlling optics, and that is, of course, orthokeratology. Now, many of you are familiar with some of our histologic work related to the epithelial's response to orthokeratology, and there is no doubt that these changes are extremely geographic in nature. That is, here we can see the slight thinning of the central epithelium and the thickening of the mid-peripheral epithelium at the edge of the pupil. It's interesting to note that where the epithelium is actually the thinnest is not in the central portion of the cornea, but out where the alignment curve is presently on the lens. Now we can see here that that thickening of the epithelium in the area of the reverse curve is what actually creates that plus power that we're trying to introduce into the child's eyes. That can be seen so nicely, not in the axial display map, but of course in the tangential display map. Here we can see the red ring created by the thickening of the epithelium, and you see that blue area outside of the red ring. That is where the epithelium is the thinnest. Where the epithelium is the thinnest, it will be blue, and where it is the thickest, it will be red. Now notice, in the center of this cornea, there's a little blue area, and that is where the epithelium has thinned slightly, but nowhere near as much as what it has in the peripheral cornea. Now, obviously, what we're trying to do here is to manipulate the shape of the image shell of the child. That is, when we place a child into a minus correcting spectacle lens, as we see in the upper left, the central images are indeed focused on the fovea, but peripherally, those rays of light fall outside of the retina. Our goal here with orthokeratology is to take that myopic correcting optic and now bring it in so that those peripheral rays of light can focus inside the eye. And here we can see that in a rather nice illustration of a patient post orthokeratology. Now, one of the important things that has come up through a variety of different studies is the fact that we need to quantitate, understand the amount of hyperopic plus power we're introducing into the eye. There are numerous animal and human studies that appear to indicate that the stronger this signal is, i.e., the greater the amount of plus power, the better the myopia control. Now, we could see this in this 2011 study from the Hong Kong Polytechnic University. And we see here that in a group of chickens, a signal has been adjusted to be in myopic defocus, that is the good stuff inside the eye, and hyperopic defocus. Well, the results of the study were pretty clear, and that is when myopic defocus was created with the plus powered lenses, the eyes drew significantly less. As that plus power dissipated and became more minus power, the eyes elongated. So this was one of the real early indicators that the strength of signal is going to be an important part of the future of myopia control. More recently, in 2020, the results of the BLINK study were published, and here a group of children were exposed to two different powered multifocal soft contact lenses, one with a 250 ad, the other a 150 ad. The results were pretty clear in that treatment with the higher ad multifocal lens, the plus 250, significantly reduced the rate of myopia progression over 3 years compared to the 150 or the control group that was just wearing a single vision lens. So you could see here that this concept of strength of signal appears to be an important part of this myopia control study. Now, one of the things we've had to struggle with is how can you and I in clinical practice determine the strength of the signal? You see, what we've done in the past is we told mom and dad that we're going to place the child in Ortho-K lenses, and there's a 50-50 chance that we're going to get good myopia control. Well, that can be really seen here very nicely in just 3 simple slides. We're going to look at 3 Ortho-K results, all of them a -3 diopter correction. Now you can see here that in this particular patient, we have a very well-centered treatment zone, a nice -3 correction. And you can see here that despite the -3 correction, we're getting a very weak ad power at the edge of the 5mm optic. Here, we're only getting a 1 + 1.5 dioptric power. Now, let's look at our second patient. This patient, too, had a 3 diopter change. And here we have a stronger ad power, a +2.25. Nice center treatment, just like our previous patient, but a significantly more powerful add power being presented within the 5 millimeter pupil. Now, on our third patient, once again, another -3 correction. And here you can see we have an +3 add power. So 3 individual patients who have undergone very successful orthokeratology, all 3 of them ended up with significantly different peripheral plus powers. So if our goal in orthokeratology is to provide the child with a reasonable amount of add to slow or stop the axial growth of their eye, it is clear that this child perhaps has the best chance of undergoing successful orthokeratology for myopia control. Now, is there another index by which we can measure this all-important strength of signal? And that was really made clear to us in this beautiful study that was done by 2 of our finer myopia control universities. That is the Hong Kong Polytechnic University and the incredible work of Pauline Cho, and the incredible work going on with Stephen Vincent and his group at the Queensland University of Technology. What they did is they looked at 103 children who had undergone orthokeratology and measured the amount of spherical aberration induced by the procedure, by the orthokeratology. What you see here are 2 cohorts. That is 190 eyes that had very poor myopia control and 252 eyes that had good myopia control by virtue of their axial lengths at this 2-year window of time. And you could see here that those with poor myopia control had small increases in their spherical aberration, that is 0.22 microns. Whereas the group that had good myopia control, they had a higher amount of spherical aberration, 0.74 microns. Now you're looking at this kind of thinking, wow, this is kind of interesting that increasing spherical aberration is associated with a better myopia control result. Is there a way that we can measure this in clinical practice without purchasing an aberrometer? Well, the answer is yes, and that is by looking at corneal aberrometry. Since most of the effects of orthokeratology are indeed corneal, it would make sense that if we understand these changes, perhaps we might have another tool for determining the strength of signal. Now, here we're going to look at corneal aberrometry, this time from the Medmont corneal topographer. We're going to look at 3 individuals who have undergone successful orthokeratology with -2.5 diopter results. And you could see here that this individual has a correction of -2.57 diopters, a myopic defocus dosage, that strength of signal of +1.5 diopters. Now, when we look at the pre and post corneal aberrometry, we see in this individual 0.83 microns of corneal aberrometry. Now, let's look at this next patient. Notice we have again a -2.5 diopter correction, but our myopic defocus dosage has gone from 155 to 2 diopters of plus power in this particular patient. And now that spherical aberration has increased from 83 microns to now 94 microns. And in our third patient, again, a -2.5 diopter add, but here we're getting a pretty strong myopic defocus dosage, a strength of signal of 2.5 diopters. But notice with that, we've increased the spherical aberration to 1.23 microns. So here in clinical practice, we've been able to see how effective the delivery of this plus power has been on this patient, our second patient, and our third patient by looking at the amount of myopic defocus dosage at a given 5.0 millimeter pupil, and by measuring the amount of corneal aberration present in the individual. So this is rather exciting in the fact that this may be the way we can have some pretty effective biomarkers to determine how much plus power the child is receiving. Now, in response to this, it's become clear that we may have a stronger signal being introduced to the child's eye by controlling where that red ring ends up and controlling the size of that central treatment zone. Here we have another individual with a 2.5 diopter change, and here this individual is wearing a 6 millimeter optical zone lens. By manipulating the size of the optical zone from 6 millimeters to 5.5 or 5.0, we can see a dramatic change in our power profile map down below.
Miro 1 month delivers one of the highest levels of oxygen transmission available in sphere, toric, and multifocal Miro 1 month contact lenses from Menicon.
That is to say, we have now become obsessed with these maps. These maps give us some indication as to the amount of plus power the child is receiving by the profile created by these maps. We arbitrarily select a 5 millimeter pupil because that is the average size of a child's pupil. Now, a lot of individuals get really obsessed with this pupil diameter situation, but it's important that we understand that pupil diameters are changing constantly with the child throughout the entire day. So for us to understand this, we have to set the pupil. And for us in clinical practice at Pacific University, we have selected a 5 millimeter pupil. And here we can see in our two patients, both with 2.5 diopter changes, a rather significant difference in the amount of plus power presented through these two pupils. Which one of these individuals is going to have the best myopia control? Well, time is going to tell. We're going to get that information. It is currently being studied around the world, and very soon these information and data are going to become available to us. For us right now, we have to put our best foot forward. And therefore, when we are presenting orthokeratology to parents and children, we like to vary the size of the optical zone to give the child the best dosage possible. And that means by going to the smaller optical zone, we hope to be able to place that red ring, the plus optics, greater within the pupil margins. Now, for this reason, we have two different lenses. We have our 5 and 5.5 millimeter optical zone lenses we use for our younger myopia control patients, and we have our larger 6 millimeter optical zone, which we call our adult orthokeratology lenses. The unfortunate part is today the bulk of the lenses being manufactured for myopia control are a fixed 6 millimeter optical zone. Now, optical zone is not the whole story to this saga. That is, when we start decreasing the size of the optical zone, we're going to drop the depth of the reverse curve. Up on top, we see a 6 millimeter optical zone Ortho-K lens design. We're going to take that design and shrink the optical zone down to 5.5 and ultimately 5 millimeters. Now, look at the depth of the reverse curve. By making the reverse curve depth shallower, we're going to decrease the amount of plus power being generated into the child's eyes. So along with the smaller optical zone, we have to use an aspheric base curve radius. What this does is it dramatically changes the profile of the reverse curve. So instead of using a sphere on the backside of the lens, we simply make it aspheric. The end result is that all three of these lenses are going to be designed to deliver a maximum amount of plus power, preferably 3 diopters of plus power or greater over the child's pupil. Now, that can really be seen in this particular study. This is a study that was done by Eddie Chow in Toronto, Canada. Eddie has the largest myopia control practice currently in North America. And Eddie was interested in looking at two different cohorts of patients. That is, a group wearing a traditional 6 millimeter optical zone lens, and a second group that was wearing a smaller optical zone, 5.4 millimeters, with that aspheric base curve radius. Now, these two cohorts were followed for 5 years with their axial lengths. To make the study groups equivalent, we used a propensity analysis grading system by which we were able to match the two cohorts of patients with their age, axial length, the spherical equivalent power, keratometry, eccentricity. At the end of the propensity analysis, we had 191 eyes in both study groups that were equally matched when they began their orthokeratology adventure. So let's first take a look at the 5-year axial length results of those individuals wearing a traditional 6mm optical zone lens. You could see here that when compared to a control group, in this case, the clear study data group from Ohio State University wearing spectacle lenses, we see here that some of the children did very well with their myopia control, and others did rather poorly with their myopia control. It's pretty easy to see when you look at the dioptric powers down below. The higher the myopic power at the time of the beginning Ortho-K, the greater the myopia control of the child. Now, when these were placed onto a scatter chart, you could see here that we had two very distinct groups of patients, those that responded well to Ortho-K and those that didn't. And by doing a pretty quick glance here, you could see that the numbers were close to 50-50. Now, when we look at our myopia control studies in the literature, we see here that the average amount of reduction in myopia is around 50%. That is, half of the children do well with the myopia control, half of them don't. Now, all of these studies have used the 6mm optical zone design, and they're probably all going to get this very similar response to that particular design. Now, if having a 50% success rate is adequate in your practice, my gosh, just carry on and continue doing that, and hope that these things get better with time. However, if 50% is a little disconcerting to you, let's see why that might be. We notice here that when we do a -1 correction on top and look at the tear film profile beneath the Ortho-K lens, we see a very small reverse curve, and therefore it's going to be very difficult to induce any significant amount of plus power with that kind of tear film profile beneath the lens. Now you can see a dramatic difference with the -4 RX. Now we've got a significantly deeper reverse curve, and now we're probably going to get the desired plus power we're looking for. When we look at individuals who have undergone the power profile maps with orthokeratology, a -1 is going to induce a very small amount of plus power, whereas a -4 is going to induce a significantly greater amount of plus power. That is just the way orthokeratology works. Now, in the second cohort of individuals, 191 eyes, who had been followed for 5 years and randomly selected through propensity analysis, here we could see a 5.4mm optical zone, a posterior asphericity of 1.40, and now we can see, in following those children for 5 years, a much better myopia controlling result. When we compare the two groups, we could see the 6.0 in the green, the 5.4 in the yellow, a pretty significant difference. And when we look at our scatter chart, we could see here much better controlling results with the aspheric 5.4 millimeter OZ lens designs. So it is clear to us now that in dealing with our myopia control patients at Pacific University, we pay very close attention to this strength of signal. That is, in our lower myopes, it is critical that we place them in Ortho-K lens designs that are going to be able to generate enough plus power across the pupil to be equivalent to a +3 add power. And the only way we can do that is by making the optical zone smaller and putting in an appropriate amount of asphericity to create that design effect. Now, another modality that is often overlooked today is a front surface aspheric GP lens design. Now, what these are is they are very large diameter lenses equivalent to the same size we use for orthokeratology, between 10.5 and 11 millimeters. The wonderful thing about these lenses is that they are daily wear, large diameter GP lenses, which allow us to use these lenses in a back surface toric design for highly toric children that need myopia controlling optics. The plus power is just generated on the anterior surface of the lens, just as they would with an anterior surface correcting aspheric multifocal for presbyopia. We can vary the amount of eccentricity to create very little add power, or we can put in a significant amount of asphericity to create the desired amount of plus power we need. So we can control the strength of signal by just simply adjusting the asphericity on the front side of the contact lens. Now, for families that are reluctant to have their children sleeping in overnight orthokeratology lenses, wearing a daily wear multifocal aspheric contact lens may be very, very beneficial for the child, especially those with higher degrees of astigmatism. Now, in a study done at Pacific University, we basically found that we can, again, control that strength of signal by just simply changing the asphericity on the front of these contact lenses. As you can see here, we're looking at two different lenses, and we're looking at the peripheral refraction profiles. We see our baseline in the black. We see our +150 add and our +3 diopter add powers. So we could see here again that we can control the strength of signal by changing the asphericity on the front side of the lens. Now, to measure this in a rather different way, we decided to kind of build upon the work that had been done at the Queensland University of Technology, and that is by measuring the response of the contact lens, the anterior aspheric optic, to the thickness of the choroid. For a number of years, observations have been made that when the eye is in hyperopic defocus, that is the bad stuff, where the rays of light focus behind the eye, the choroid's response to that is to thin. And when we have myopic defocus, call it the good stuff, we see choroidal thickening. Now, the interesting thing about this response is that it happens very quickly. Within minutes after the contact lens has been placed onto the eye, these changes can be seen, especially in certain geographic areas of the choroid. There appears to be a hot spot. That is a spot on the choroid that seems to be incredibly sensitive to this defocus, be it hyperopic or myopic defocus. It is in the superior mid-periphery of the choroid. So what we did was basically placed a group of individuals into two different contact lenses. That is, you could see here in this individual, we have a 10-3 diameter anterior aspheric multifocal. On the right eye, we've incorporated a center distant design where the center 2 millimeters are for distance, and around that area we have our peripheral +5 add power. And on the other eye, we have a spherical contact lens. Now, we have the individuals wear these contact lenses for relatively short periods of time, and that is approximately 4 hours. Now, you can see here the difference in the response of the choroid to these two contact lenses. You could see the spherical lens on the left in red, its choroidal thickness response, and you could see on the right eye with the +5 add, we definitely have a pretty strong response in that superior and inferior periphery of the choroid. Now, the interesting thing about this particular study was the individual's subjective response to the eyes wearing the +5 add power. While they noticed some blur in the periphery created by the +5 lens, the response was surprisingly minimal. That is, all of these subjects were able to successfully wear the contact lenses in both eyes for the 4-hour period. Now, this kind of surprised me because that's a pretty substantial amount of add power, but nonetheless, subjectively, they did surprisingly well. Now, on subject number 2, this time we had the +5 add power on the right eye, again, the sphere on the left, and here again, you can see the response of the two eyes, and you could see it especially in the +5 add in that superior portion of the choroid. So this perhaps is another biomarker that we're going to be able to use in the not too distant future to determine the response of the choroid to these various types of defocus, be it hyperopic or myopic. So once again, a very kind of exciting body of work that needs to be done in this particular area. Now, let's change gears and look at our soft contact lenses. Now, today, the market for myopia control multifocal soft lenses is dominated by center distant lens designs. And as we know, there are many different profiles that have been used for a variety of different studies. The one that has created the greatest amount of interest in recent time is the CooperVision MiSight lens. Now, this is an alternating distant, near type of lens design called a dual focus lens design. And here again, their results have been very intriguing. Now, we have to backtrack a little bit because we need to take a look at a small body of work we did related to the peripheral optics of our daily disposable soft contact lenses. Let's say we have a child come in who's a -3 myope, and we decide not to do myopia control on the child, but instead place the child, be it a 13, 14-year-old individual, into a daily disposable lens. Now, is that the smartest thing we can do? Our data seems to indicate that the answer is no, because our data in analyzing the power profiles of these lenses from center to a cord of 6 millimeters indicates that these lenses become more minus from center out to the periphery. Now, that's the opposite direction we want to go. That is, we want the lenses to become plus in the periphery and not minus. We could see here in this -3 diopter window, a multifocal soft lens, in this case, the CooperVision MiSight, instead of becoming more minus in the periphery, it naturally becomes more plus. And when we look at the maximum amount of plus power induced by a -3 CooperVision MiSight lens, with this measuring technique, we get a plus 1.37 diopter maximum add power. Now, if we look at a cohort of -6 daily disposable lenses, we see they too increase in minus power, but to a greater degree than the -3. And we could see here that the -6 MiSight lens created an add power of plus 1.12 diopters. Now, where am I going with this? Where I'm going with this is that it is going to be important in the future that the various manufacturers making contact lenses provide us with accurate power profile maps that provide us with information as to the dosage of plus power that our children are receiving through these lenses. Now, this is with a Hartmann-Shack measuring apparatus. We also measured it with the Rotlex instrument, and we could see here the various amounts of add power, this time with the AccuView Oasis plus 250 multifocal. Over on the right, you can see the maximum amount of plus add power we were able to identify in those Oasis lenses. On average, it was a add power of plus 1.5 diopters. In the CooperVision center distant biofinity lens, again with a plus 250 add power, Our average amount of plus power throughout the lenses that were measured was 1 plus 1.7 diopters, significantly less than what was labeled on the container. And with this measuring technique, our MiSight lenses fared a little bit better with a plus 1.9 diopter increase in plus power. So you could see here, this today becomes a very important criteria. The last one I want to provide you with is the natural view myope multifocal lens. And this, as you could see, has a much larger optical zone further out in the periphery, but it had an average add power plus 1.4 diopters. Now, if we look at these 4 center distant multifocal lens designs, and we look at the -3 lens powers, we can see here in the green the difference in the size of the treatment zone, or the area which has been dedicated for the distant optic. As you can see, it's really pretty dramatic, so that an individual child is going to get different responses from all 4 of these lens designs based on the position of the red ring or the position of the maximum plus power. If we look at these -3 lenses based on their maximum add power, we could see here in the AccuView Oasis plus 150, Biofinity plus 1.57, the MiSight 1.9, and the Natural View plus 2.60. So we're getting very, very different results based on the various multifocal lens designs. Now, if we look at these various multifocal lenses with the Hartmann-Shack-based metrology, we see here again that the various lenses are not giving us the same amount of plus power as is listed on the label of the contact lens. Now, if you ask any practitioner in clinical practice, what is their primary problem with multifocal lenses for presbyopia, it's always the same answer. That is, I just can't seem to get enough plus power in the contact lens. Could it be that we're not getting the amount of plus power because maybe it's not there? And this is something that the manufacturers are going to have to work with us. We are providing our children with a dosage similar to any medication. We need to know what the medication is. We need to know the dosage of that medication. And when we're doing myopia control, this becomes incredibly critical to us, if indeed that peripheral defocus theory is correct. Now, another obstacle that we face in the delivery of multifocal optics with our children is centration of the soft contact lens. Now, I know that sounds a bit peculiar, but our studies at Pacific have clearly shown that the sclera on the nasal side of the eye is very different from that on the temporal side. And when these lenses land on the sclera, they are going to land first on the nasal side and then come to rest in a slightly decentered position. Now, if this is a single vision lens, it creates little or no problem for the patient, this minor amount of decentration. That is, if we were to ask any practitioner, is this lens adequately centered? Of course, the answer would be yes, it's adequately centered. Now, we can really see this in this particular cartoon, in which we have an underlying anterior segment with the cornea and sclera. And I want you to pay attention to where this lens ultimately positions. We have marked the line of sight in this individual, and that is always going to be nasal, and that is due to the temporal position of the human fovea. So we could see here that the optics being in the center of the contact lens are marked by that yellow star. Now, watch as the lens drops and hits the nasal side of the sclera. It's going to drop down, hit the nasal side, and it has to come to rest on the other side. And ultimately, it lands in this naturally occurring decentered position. Now, pay attention to where the central distant optic is compared to where it should be on the line of sight. So these lenses actually position opposite of where we would ultimately like them to be. And this could be a potential problem for our children. It's obviously a problem for our presbyopic patients. And we really don't understand fully why the nasal sclera and temporal sclera should be somewhat different from one another. The only thing we can surmise is the insertion of that medial rectus muscle, which is only 5.8 millimeters from the limbus, compared to the insertion of the other extraocular muscles. Now, whether or not this is playing the primary role in the shape of the nasal sclera, we really don't know for sure. But suffice it to say, our lenses are going to decenter. Because of that decentration, our optics of our multifocal soft contact lenses are going to be compromised. Here we see a center near multifocal lens design with the optics displaced slightly temporal. And now when those optics are displaced by the laboratory and the lens properly ballasted, we can indeed position those optics exactly where we want them to be. When we're using these higher add powers in our children's multifocal soft contact lenses, it is going to be imperative that we get those optics very well centered. And so this is another area of great research in the future. Now, finally, I'm going to end up with a little bit related to spectacle contact lenses. We've known for many years that when we place a child into a spectacle lens for correction of their myopia, that it induces the bad hyperopic peripheral defocus. Now, the reason this is of great concern today is that we are diagnosing myopia in younger and younger children due to very effective school screenings and our optometric advertising that has done a very good job of identifying or directing parents to bring their children in for eye exams. So the question is when that myopic child presents to our office, do we really want to put them in spectacle lenses? Well, there was a beautiful study done by Lin et al. At the Brian Holden Vision Institute, where they looked at peripheral refraction of low and moderate myopes. As you could see here, what we see are the average results of the low myopic group and the moderate myopic group down below. And we see the differences in central and peripheral refractive error.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
Now, when those children were corrected, you could see here that the amount of hyperopic bad defocus was greater in the children with the higher amount of myopia. They were equal at the fovea because they were both corrected, the low and moderate myopes, to their full foveal correction. But peripherally, as the minus power increases, so does the hyperopic or bad defocus. The conclusions of their study was rather significant and yet rather misunderstood or just simply negated by the eye care community, and the fact that their conclusion was that single vision spectacle lenses induce absolute hyperopic defocus on the retinal periphery of low and moderate myopic children. And yet today we continue to do what we've done for the past 400 years, and that is place many of these children into spectacle lenses. Well, we decided to take a look at these spectacle lenses and see how much minus power is induced in them. And here we're going to look at the results of -0.5, -3, -6, -9, and -12 Hoya spectacle lenses. And we could see the amount of myopic power increase over a 40 millimeter central zone. And here in the Shamir lenses, you can see, especially in that -12 lens, a rather significant amount of myopia induced. Now, that is why many of our spectacle lens companies are coming out with spectacles for myopia control. And while some of these have had limited success, I believe that we have just really scratched the surface. That is, the results of the DIMS study conducted at Hong Kong Polytechnic University appeared to provide some rather interesting results. I know this is an extremely busy slide, but I'll go right to the bottom. The children wearing the DIMS spectacle lenses had a 59% reduction in myopia progression and a 60% less axial length elongation over the course of this 2-year study. So again, I think we might be onto something here. We may have another alternative for our children. Now remember, all of these data are average data. Some respond very well, some respond very poorly. The onus is on us to identify the individual child's response to these various therapies. And when we pick up individual children's increases in axial length, we have to be able to make changes very effectively and quickly to get them in a modality that will hopefully slow down their myopia. So when you're looking at these data, while they look very exciting and intriguing, and indeed they are, we have to remember we're dealing with individual patients. Now, some good news, at least for those of us in North America, Hoya in July of 2020 launched in Canada, and we're going to hopefully in the United States someday see this type of technology introduced, so we have another tool in our toolbox. Now, there's also another group. It's called Sight Glass Vision out of Palo Alto, California. They've got a CE mark in Europe for distribution of their diffusion optic technology. And it too looks like it's having some pretty significant results. So again, I'm very excited about these spectacle lenses for myopia control, in that there is probably going to be a cohort of patients that have a very positive response to these modalities. Now, we'd be remiss if we didn't say a few kind of closing words on pharmacologic intervention. And of course, when you talk about pharmacologic intervention, you're talking about atropine. And of course, we are all familiar with the results of the 1% atropine drops that seem to indicate that we were getting a good myopia controlling effect, both refractive and axially, with these pharmacologic interventions. What threw the industry into quite a stir were the results of the ADAM2 studies, in which 0.01% atropine was used, and still they found a 59% reduction in refractive error in these children. Now, it's very important to remember that when children are on atropine drops, getting accurate refractive data is extremely difficult. Even with low doses of atropine, we get very mixed and muddy refractive data. Therefore, we have to go back to our gold standard, which is axial length data. And here we can see that the results of the ADAM2 study appear to indicate that the placebo that was used in the study actually had a better result than the atropine drops, the low-dose atropine. Subsequent to that, a number of different studies have been done looking at how effective low-dose atropine actually is. And here is one of those studies published in Ophthalmology in 2018, where they looked at the various concentrations of atropine. And we could see here the changes in axial length appear to definitely be dose-related. That is, here in this initial results of this study, which we're seeing here, 12-month data, the low-dose atropine had the lowest myopia controlling effect. The best myopia controlling effect was seen with 0.5% atropine. So here again, we see it does appear to be a dose-related phenomena. Now, does that put the final sword into the heart of atropine? The answer is not really. And that is because there have been a number of studies now looking at combined therapies of atropine with orthokeratology. This is one of those that was just recently published, the one-year data from the Hong Kong Polytechnic University. And what we see here is the atropine orthokeratology axial length at 6 and 12 months. We see here that at 6 months, there's a pretty significant difference between the two groups. But then again, at 12 months, they seem to take a more parallel course. Now, whether or not this is going to be true throughout the course of atropine with Ortho-K remains to be seen, but nonetheless, it's very clear that the combined use of atropine, low-dose atropine, with orthokeratology appears to have a pretty positive effect. Now, if we look at 1 year, now granted, this is 1 year data, and that's all we have at this particular time, so we have to deal with what we have. Would we love to have this 10-year data? Of course, but we're going to take a look at our 1 year results. Here we can see in this study, published in 2019, looking at the 3 different doses of atropine compared to a control. We could see here a pretty linear change going on based on the dosage of the atropine. Now, in this particular study, we're going to change gears a little bit and look at a control group and a group that has undergone orthokeratology. Kind of interesting here when you look at orthokeratology's response and that of the 0.05% atropine, virtually identical. Now, in September of 2018, there was the study showing Ortho-K effect and low-dose atropine and Ortho-K. And here we can see that Ortho-K alone, 0.19 increase in axial length, compared to a equally matched group of individuals using atropine and Ortho-K. And in the current study that we just reviewed with you, we see the Ortho-K group on top and the atropine and Ortho-K group down below. So you could see here we now have 2 studies indicating that this combined treatment appears to have a very positive effect, at least at 1 year. Now, it's interesting if you just kind of look at the numbers and you look at the reduction related to just orthokeratology. On average, it's 52%. With atropine, low-dose atropine, it's only about a 12% reduction. However, when you combine those 2 therapies, at least the 1 year data indicates a 76% reduction in myopia. Stay tuned. I don't know how well these numbers will hold up with time, but we're seeing some interesting things happening. Now, why the synergistic effect of the atropine and the Ortho-K? Well, all we can surmise is some conjectures. Number one is pupil size. Even with low dose atropine, there's a little bit of pupil dilation. And does that extra pupil dilation induce a little bit more of that myopic defocus image in the periphery? Does it create a stronger signal within the eye? Perhaps it does. So the other may be the actual trapping of the atropine in the reverse curve of the contact lens. That is, if the drop is instilled into the child's eyes and the Ortho-K lens applied to the eye, does some of that residual atropine get trapped beneath the reverse curve of the lens and get slowly but more thoroughly released into the eye? These are all just conjectures that we have come up with that might explain some of this synergistic effect, but this is definitely a story that we're all very excited about, and we're going to wait and see. Well, in summary, as of today, thousands of articles have been written on myopia control, and yet we have not identified the cascade of optical and or neurotransmitting chemicals involved in this myopia story. That is, we know that when we do orthokeratology, we know that when we increase strength of signal, it appears to have a stronger myopia controlling signal within the eye. But what is actually physically happening with those stronger signals remains unknown. I'm confident that within 5 years, we'll probably have the answer to this. But for now, we've got some pretty sound data to give us the green light to move forward with our myopia controlling strategies. So for now, the future of myopia control looks very, very bright. However, as I mentioned in the opening of this lecture, it's very, very important that we remember that each individual patient we see is going to have their individual response to our therapies. That means that all of the onus is on us to identify the child's response to our therapy. We have many different tools, as I outlined, and finding the right tool for that individual patient is a lot of trial and error right now. And I don't see that changing in the distant future. I think we're going to always have this as part of our myopia controlling saga. Right now, the best we can do is measure our strength of signal as best we can and follow axial lengths to determine whether we're seeing a control of the myopia or further increase in the child's myopia. With that, I want to thank you for your kind attention, and I sure look forward to seeing all you again down the road once everything is back to normal. Thank you very much.